tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana bilang ating sentenaryo, ay biglang natapos din. 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, may busilak ng utak at puso. Kailan may di nagkulang sa talino at talento. Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan may di nagkulang sa talino at talento. Ilang dekada pang tayo'y magkakasama, sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating itiling, karangalan at galing sa lahat ng ating gawain. Pagsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala at kwento natin ng katuwa at pighati, sa lahat ng pangyayari na naghubog sa atin. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, may busilak ng utak at puso. Kailan may di nagkulang sa talino at talento. Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan may di nagkulang sa talino at talento. Philippine medisina.
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary health care in the era of universal health care. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, We encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Hi, everyone. Happy Monday. I hope everyone is having a good start of the week. I'd like to welcome everyone joining us on Zoom and those watching the Facebook and the UP Manila live streams. Before we proceed, I'd like to introduce myself. My name is Awi Kurameng. I am a specialist medical communicator, and I currently serve as Regional Medical Director of the MIMS Group, and I'm joining you from Hong Kong. Last but certainly not the least, I am a proud member of the UP College of Medicine class of 1998, this year's Silver Jubilarians. I'm very privileged to be moderating today's webinar. Okay, so let's dive right in. I'm delighted to introduce our esteemed guest speaker, Dr. Kenneth Samala. Dr. Samala is a thoracic oncology fellow at the University of Alberta Cross Cancer Institute in Edmonton, Canada, and he is a consultant at Manila Medical Center, Manila. He is a proud member of the UP College of Medicine class of 2011. Today, Dr. Samala will take us through the diagnosis and workup of lung cancer in the Philippines. So, Dr. Samala, thank you so much for taking time out to join us today, and the floor is yours, sir.
All right, so let me just share my screen. Oh. Can you see my screen now? There.
Yes, Doc.
Okay, so thank you, Doc Awi, for that kind introduction. So good afternoon to all our participants for today's webinar. First of all, I'd like to thank the UPCM class of 1998 for organizing this very timely webinar as we celebrate Lung Cancer Awareness Month this November. I'd also like to thank Takeda for sponsoring today's webinar. So I'm Dr. Ken Samala. I'm a medical oncologist and currently doing my further training in thoracic oncology here in Canada. So here are the objectives for today's webinar. So we'll try to review some relevant information regarding lung cancer and understand the challenges of diagnosing lung cancer in the Philippine setting. So later on, we'll tackle what's unique in diagnosing lung cancer here in the Philippines. We'll also try to differentiate tuberculosis from lung cancer, probably through clinical and radiological features, list the different diagnostic modalities for lung cancer, and at the end, give you or help us understand some of the newer emerging modalities that might be available for us in the near future in terms of lung cancer screening and diagnosis. So this will be, again, the outline for our lecture. So to kick off the discussion, so I'll use an hypothetical case of a 55-year-old man named Juan. So throughout this lecture, we'll try to follow his journey and hopefully learn more about what our patients go through. So he presented with a 3-month history of cough with whitish sputum. He also had dyspnea on moderate exertion and loosening of his clothes. So basically telling us that he is losing weight in the past 3 months or so. His appetite has slightly gone down as well. So he does not recall any episode of fever during this time. And he works in an office, but is a current smoker, about 30-pack year smoking history. So I'd like to start any cancer lecture with its incidence or prevalence, just to give us a good grasp of how big of a problem it really is. So the current data as of 2020, according to the GloboCan, is that globally, there were about 19.3 million new cases of cancer worldwide. The sunburst diagram here, let me just use so these are so the sunburst diagram here illustrates the distribution of new cancer cases by color in terms of region. So basically, by eyeballing alone, you can see that about half of the new cases for cancer are from Asia, represented by the purple hues. So, of course, the number of population significantly impacts this. Looking at the Philippine data on your right, the Philippines contributes to about 0.9% of new cases worldwide, and that accounts for about 153,000 new cases in 2020 alone. Looking closely at the figure below, it shows the breakdown of all the cancer types of or types of malignancies contributing to the Philippines cancer incidence. So breast cancer, still the greatest number of new cases in 2020, followed by lung, and then colorectal, liver, prostate, cervical, and thyroid. Now, let's see how the future looks like in terms of the cancer incidence in the next few years. Sadly, we see this upward trend in the number of new cases from 2020 to 2040, is about 20 years after. By then, it is predicted that about 30.2 million new cancer cases will be observed by 2040. Pretty much the same trend for the Philippines. It will jump to about 275,000 new cases of cancer by 2040 from 154. So that's nearly 50% jump. So clearly, cancer will stay as a significant health problem worldwide and even locally, unfortunately. So now let's zero in on lung cancer. So in a nutshell, lung cancer, it's any type of malignancy cancer that begins in the lungs. It may even spread to your lymph nodes or other organs in the body, such as the brain, the bone, or even the liver. Cancer from other organs that also may spread to the lungs. So that's a different story. But when cancer spreads from one organ to another, they are called metastases. So lung cancer are generally grouped into two main types. We have the small cell, which is around 15%, and about 85% are actually your non-small cell. And your non-small cell lung cancer includes your adenocarcinoma, your squamous cell, and your large cell as well. So it's very important for us clinicians, especially for the medical oncologists, to sort of like determine which type of cancer a patient has, because it will matter very much significantly in terms of like treatment options and in terms of prognosis for our patients. So that's why it's very important to subtype them or to determine the type. So what are the risk factors for lung cancer? So as you might have guessed it, yes, smoking is still the leading cause of lung cancer, contributing to about 90%. But there are other risk factors as well. A family history of lung cancer. Unfortunately, even exposure to secondhand smoke. So even if you're not smoking, but your loved one or someone you're close with is smoking, then secondhand smoke can definitely contribute to increasing one's risk of developing lung cancer. Other chemicals or occupational exposure, for example, asbestos, can also increase the risk of a thoracic cancer, specifically mesothelioma. So many decades ago, we've used like asbestos in terms of like insulation for buildings and houses, but it's not being used currently. But I would imagine that the older buildings might still have some asbestos with them. So normally, routinely, depending on where they were constructed, you sort of like do some asbestos tests as well, just to determine if asbestos is present. Environmental exposure as well, specifically in some homes can be exposed to some dangerous levels of radon. This is a bigger problem, I would say, in other parts of the world, especially in the Western Hemisphere, but it's not really a big problem in the back home in the Philippines. So, but current data have shown that even non-smokers can develop lung cancer as well. And this is usually pegged at around, 10 to 20%. Although there is a new data that just came out here in Canada. It seems like the incidence of non-smokers developing lung cancer is steadily increasing. It's now pegged at around 28 to 29%. So that's not very good news. So interestingly, we see a profile for lung cancer patients who are non-smokers. So they are generally females. Normally, when we do biopsy, they're usually adenocarcinoma. Most of them will also have like sort of mutations. We'll talk about this even for more in the next few slides. So some of them can have this sort of mutations that we can do certain tests with. And usually they can also have like underlying lung disease, like for example, pulmonary fibrosis. So these are the things that, can probably also, you see in patients that are lung cancer, but they're non-smokers. Okay, so after that very brief introduction to lung cancer, let's now try to understand a Filipino lung cancer patient's journey from the time of initial presentation to his or her first consult, to the use of diagnostics, and to confirm the disease, and finally, when treatment is actually started. So, before we proceed, I'd like to say that I wanted to talk about the diagnosis and workup of lung cancer specifically in the Philippines setting, because we do have a unique challenge with us. So what I think is unique in treating a Filipino lung cancer patient are there's definitely inherent challenges with the disease. I believe that the Philippines has a double burden because of lung cancer. Number one, majority of the lung cancer cases that we diagnose here in the Philippines are already in the metastatic stage, or those are already the stage 4 or very advanced. About, I would say it's around 60% are already in the metastatic setting. And this is without any treatment, or the survival, the 5-year survival of these patients is very dismal at 2.9%. The other thing that you probably already knew from my outline is that aside from patients are being diagnosed already at the later stage in the Philippines, we have a very high tuberculosis burden. According to the Philippines TB Joint Program Review, we have 1 million Filipinos with active TB cases, so that's roughly like 1% of the population. And unfortunately, nearly 70 Filipinos die of tuberculosis every day. Okay, so here is a slide like focusing on how big of a problem tuberculosis is in the Philippines. So in 2021, 8 countries accounted for more than 2/3 of global TB cases. And you guessed it right, Philippines is part of it. So number 1 is India, followed by Indonesia, then China. Philippines comes at fourth. We We have Pakistan, Nigeria, Bangladesh, and Congo. So looking closely at the Philippine data, unfortunately, there seems to be sort of like this upward trend in estimated TB incidents starting in 2020. And we all knew what happened in 2020, that's when the pandemic started. So I would have to say that for the longest time, it's been steady, sort of a small dip by the start of 2020, but back in 2020, it started to rise. So that's not very encouraging for the current state of TB control in the Philippines. And according to the National TB Control Program, as of 2022, we have about a quarter, 372,000 known drug-sensitive and drug-resistant tuberculosis in the country. So what is now this sort of contribution of high TB burden in terms of accurately diagnosing lung cancer? And there's this a very important article published in 2016. They likened this challenge as merely just hitting the tip of the iceberg for low to middle income countries with high TB prevalence, basically like the Philippines. These are just some of the factors that complicates lung cancer diagnosis in high TB burden countries. So it can complicate the diagnosis of cancers because they pretty much present the same way. There is underdiagnosis or misdiagnosis of cancer reported to be as high as around 40%. We have a very high TB prevalence in low to middle income countries. And usually because of this high TB prevalence, we sort of justify the use of empirical anti-TB treatment because we see them quite a lot. So what can be done or what can we do? I think definitely education is key, as well as effective campaigns and training for health professionals dealing with these cases. So I'd also like to say that vigilant monitoring is very important as well. If a patient does not respond to a maximum of 4 weeks, then the diagnosis should be reviewed. So definitely there's very dynamic, vigilant sort of monitoring. So if things doesn't add up, I think it's best to step back and sort of reassess the patient again, just to know if it's really tuberculosis or not. So now, let's try to list some of the clinical features of tuberculosis for both TB and lung cancer. So disclaimer, this table is not in any way exhaustive, but I hope that this provides a good guide in helping us differentiate between the two. So for example, smoking history, patients with tuberculosis, they can be smokers or non-smokers. In lung cancer, it's usually present, about 90%. Although we've talked about this a while ago, about 10 to 20% of patients are actually non-smokers. In terms of fever, you kind of familiar how the characteristic fever of tuberculosis. Usually it's low grade with evening rise. For lung cancer, usually it's non-specific. In terms of weight loss, we see this sort of slow gradual weight loss in patients with tuberculosis, but in lung cancer patients, we often see this very sudden type of weight loss, and it's probably because there's such thing as cancer cachexia, and that would also contribute a lot in terms of the weight loss. Hemoptysis can be an early feature in patients with tuberculosis, but can be a late feature in patients with lung cancer when it has already invaded some of the blood vessels or some of the tissues of the lungs. Dyspnea or breathlessness, usually it's marked and specific. In tuberculosis, it's a bit vague and dull in patients with lung cancer. Chest pain can be present or absent in patients with tuberculosis, but can be quite severe. And I've seen patients who've presented initially with severe chest pain, and then it turned out to be lung cancer. So it can be very present and severe. And when you think about the anatomy of the lungs, there might be some impingement of the nerves or involvement of the chest wall as well that contributes to the pain. Lymph nodes. Usually in TB, it's usually, if present, it can be firm, fixed, can be non-tender, painless, can be matted, and may turn into cold abscess. Usually in lung cancer, usually it's kind of hard. It's usually solitary, and if multiple, then usually it's not matted. They're usually isolated. Tenderness over the chest, usually absent in tuberculosis, but can be present in lung cancer, especially if there's like already chest wall involvement. Hoarseness is also kind of a bit rare for tuberculosis, depending on if it involved in some areas in the throat area. But normally in lung cancer, it can be present if there's already metastases, or if the mass is invading the left recurrent laryngeal nerve. We've seen that as well in some of our cases. So again, just as a disclaimer, this is not in any way exhaustive, but I hope that this table sort of like gives us a good guide, a starting guide in differentiating the two in terms of clinical presentation. Okay, so now let's try to go back to our case. So Juan, so after presenting with symptoms, of course, he then consults a physician. So normally they would present with to the general practitioners, to our family docs, to our internists, or usually pulmonologists. And usually the general practitioners are sort of the gatekeepers. You guys are the first ones who will see these patients. They would present to you. So you have a very, very significant role in terms of triaging or determining and if this patient really has TB or not. So you provide a working diagnosis. You also request the initial diagnostics that are needed by our patient. And sometimes you might have seen some patients who would present with incidental findings in their scans or in their chest X-rays. And I would have to say that this is kind of a common story as well. I've encountered patients wherein they are being seen for a totally different condition, but it turns out that they have something that pops up in their scan. So normally they would consult like physicians first, and then just to see what they are. So this is just a summary of what the clinical presentation of Juan. He has chronic cough, dyspnea and moderate exertion, weight loss, decreased appetite, and a very significant smoking history. So he did consult with the doctor. His history was taken, and his physical examination was unremarkable. And lab workups were ordered. And I would think, and I would totally agree, probably the first things that you need to usually order for this patients are your sputum AFP or a chest X-ray. Now we go to the diagnostics, or what are the diagnostics that we can use to clinch a diagnosis or help us in zeroing in on the diagnosis of lung cancer. So here are some of the, I would say, common diagnostics that can be ordered for patients with suspected lung cancer. And of course, definitely, our good old chest X-ray. It's definitely always useful. It's a noble, very modest diagnostic, but it can definitely help us in clinching our diagnosis, initial diagnosis. So definitely do your chest X-ray. And normally the story is that if we see any changes in your or opacity or any thing on your chest X-ray, that's when you usually order a chest CT scan to sort of determine or to confirm what you've seen in your chest X-ray. And then, if things are suspicious for malignancy, then definitely the next step is to get a tissue biopsy. And you can either do it two ways. We can refer to our interventional radiologists. They can do a CT-guided biopsy or percutaneous biopsy, or we refer to our friends in pulmonology. They can do bronchoscopy or plus minus your EBUS or your endobronchial ultrasound as well. So these are very important steps. If you see something that's very suspicious already on your chest CT scan, to get the tissue biopsy. And of course, right now, probably heard about this, that especially for lung cancer, and then, lung cancer is one of those types of malignancy that I would say have very mutation rich. There's so many mutations that could be present in patients with lung cancer, and we definitely want to determine which mutations are present in our patients. So we usually order, after the biopsy, the tissue sample. We do mutation tests, mutation studies, or next generation sequencing, and this will definitely help us and guide us in what treatment should be given for our patients. So we've talked about the clinical features a while ago. Now let's talk about what are the possible radiological features that might make one wonder that it's probably malignant until proven otherwise. So these are some of the radiological features that may point to possible malignancy. Again, this is not 100% exhaustive, but it might give you already an idea to raise suspicion that probably the lesions that you're seeing in your scans are actually malignant. So generally, the larger nodule, the more likely it is to be malignant. But of course, again, it does not happen all the time. But if you have a fairly large nodule, then probably you would think that it's more of malignant. You might, for example, there are some incidental findings in your chest CT scan. Normally, it's sub-centimeter. Probably it's worthwhile to check it or just do a monitoring of those lesions. But definitely, I would say if you have a lesion that's more than 1 centimeter, then probably this is worth looking into and worth doing biopsy if possible. Other important feature is the margins. So basically the description of the margin. So our friends in radiology would normally describe what they see basically on the scans, if it's irregular or speculated. So those are the, I think, magic words there. If you see irregular or speculated margins, definitely that already raises suspicion that it might be malignant already. Okay, so an irregular or speculated margins are usually malignant, but keep in mind that about 20% of malignant nodules can also have smooth margins. Okay, and lastly, in terms of growth, so lung cancers typically double in volume, so they usually grow very quick. An average increase of about 26% in diameter, and it can happen in a month's time, and can be as long as 400 days. The average is 240 days. So basically what we're saying is that if you have seen a nodule, and you decide to just serially monitor it, and it definitely has increased in size in a short period of time, again, that points to a possible malignancy. So radiologic features important: the size, irregular speculated margins, and very quick growth. So again, let's go back to our case. So after seeing his physician and undergoing tests, this is where we are right now. So Juan turns out to be sputum AFP negative. Chest X-ray initially revealed an opacity on his right middle lung lobe, so that's kind of raises suspicion. So because of these, his doctor ordered a CT scan, and it did confirm a speculated mass again. irregular spiculated mass, about 2.7 by 2.2 cm in the right lobe. And at the same time, the additional information that the CT scan provided is that they've seen, you also noted like enlarged mediastinal and subcarinal lymph node as well. Because of these, just to get a tissue biopsy, he was referred to a pulmonologist and bronchoscopy and EBUS was done. And fortunately, that did confirm that Juan has non-small cell lung cancer. And that's, once we have this biopsy already, that's, usually that's the time that we come in. And those are the time when usually patients are referred to medical oncologists. So we've seen Juan's journey. So after confirming the diagnosis, treatment can now be started. So I cannot not talk about the very important role of the multidisciplinary team, or MDT, in managing cancer. So this is definitely the standard of care, or the right way to manage any types of cancer, whether it's breast, colorectal, head and neck, and especially for lung cancer. The MDT is basically, it's a team composed of several individuals all working together with the patient at the middle, with the patient in mind. So of course you have your thoracovascular surgeons, you have your medical oncologists, you have your radiation oncologists, because we can also give radiation to patients with lung cancer. Of course, we've talked about the important role of the pulmonologist, that they can usually do your bronchoscopy or EBUS, or an interventional radiologist that can do your percutaneous biopsy or CT-guided biopsy. And of course, the nurse and other allied medical professions who also work in hand, like the nutritionists and other important individuals that usually can help contribute in taking care of our patients. So definitely, I would have to say MDT, the role of MDT is very important, even in lung cancer. So this is just a summary of all the treatment options that we have now for lung cancer. So I will not go into details on this one, but basically it was just to highlight, when we talk about lung cancer, we can actually subdivide it into two main categories: your local therapies, you have your surgery, and you have your radiation therapy. Normally, we use this in patients that are diagnosed quite early. So the early stage cancers will undergo surgery or a combination of radiation therapy and chemo. Other systemic therapies that are currently available aside from chemo, you probably heard about immunotherapy, and that's one of the, I would have to say, blockbuster drugs that we have now for cancer. It's also important to note that in lung cancer, we do have targeted therapies as well. So remember, we talked about doing mutation studies. So basically, that's where this comes in, because if we find a particular mutation in a lung cancer patient, we now have like a particular drug, usually in pill form, that would target that particular mutation. So that saves a lot in terms of like the efforts and in terms of like the side effects for patients, because it was definitely a lot more convenient to just give like pill, or sometimes we, in layman terms, we call it like oral chemotherapy, because it's, patients tend to remember it that way. But these are basically, if you want to be very specific about it, these are called targeted therapies as well. Okay, so I'd also like to take this opportunity to discuss the screening guidelines for lung cancer. So currently, we recommend screening adults age 50 to 80 years old. Number one, who have a 20-pack year smoking history. Number two, if for some reason they're still smoking, or even if for those who already quit smoking, but it's still within the past 15 years. So these are the patients that would I would recommend doing a lung cancer screening. And the modality that we use, unfortunately, it's not just your plain chest X-ray. It's a low-dose CT scan. So you can stop screening once a person has not smoked for 15 years or has a health problem that limits its life expectancy, or the ability to have lung surgery. Because, of course, if you catch like a very early lung type of lung cancer, you will want your patients to undergo surgery. But if they're not baseline not well, then it's probably not worthwhile to do the lung screening for them. You can actually stop. But these are the important, numbers to think about or to remember, like 50 to 80 years old, 20-pack years smoking history, or still smoking, or have quit within the past 15 years. Definitely, these are individuals that you can recommend for screening, specifically your low-dose CT scan. Basically, this is just another summary slide summarizing the recommendations for lung cancer screening for both in the US. So the one that I presented before this one, that's actually the US guideline. And here in the Philippines, so the Lung Center of the Philippines do have a very good lung screening program in place, and this is their current recommendation. So there is some change or a bit change from the US guidelines. So it's basically 50 to 75 years old who smoked or smoked at least one pack of cigarettes a day for at least 10 years. So this is usually the lung screening guidelines from the Lung Center of the Philippines. Okay, so we're actually moving to the last part of today's presentation, and I know it's that we talked a lot about like lung cancer and diagnosis and screening, but I want to talk about like what's in the future or what's in the horizon. So these are some of the modalities that can potentially impact the way we screen or diagnose patients for lung cancer. Most of them are still experimental. It's still not the guidelines, are still not what we usually do. But, God knows, probably in the next few years or so, this will probably be the norm or the standard of care. First is the use of your liquid biopsies for early cancer detection. This test, the circulating tumor DNA, it's been around for a while, I would say, but it still has very limited use in clinical practice. In experimental studies, it is being utilized in monitoring diseases response. So, for example, if we usually, in some of the some of the studies and researches, they would usually get the patient's circulating tumor DNA. So ctDNA, basically, that's a direct measurement of the cancer DNA. So rather than indirect measure of the effects of cancer, you probably is quite familiar, for example, with CEA for colorectal cancer. So that is an indirect measure of the effects of cancer that's not really detecting the level of cancer in the patient's body, but that's giving us a picture if a patient is actually progressing or if the cancer is coming back, if the CEA is rising. But with ctDNA, this is basically testing the cancer DNA. So in studies before, what they would do is that they would get the ctDNA before any treatment, and then the patients get chemo or any systemic therapy. And then after they end with the treatment, they would check for the ctDNA. And normally, the ctDNA is expected to go down or to reach like almost zero levels. So you know that your treatment is actually effective because there's no more circulating DNA in the patient's system. So now what they're trying to look at is, can we use this for early cancer detection? If a patient is at risk of developing a specific type of cancer, can we check his or her ctDNA levels Time will only tell if this will be an effective measure. But I would have to say that it's a very encouraging test because it's basically just your blood test now, less invasive as well. Another important evolving concept nowadays, you've probably heard a lot about artificial intelligence or AI. It's been used in many other industries as well, and medicine is actually one of them. So this particular technology has also been gaining grounds as of late. So an example is Sybil. So Sybil is a deep learning model to predict future lung cancer risks using a low-dose CT scan. So this is basically, you use your low-dose CT scan, and then you use a sort of a program to help you monitor patients. So this was done by Dr. Leticia Sequist, working at the Massachusetts General Hospital. So just to put it simply, look at here, I guess this was really amazing work. So this is a CT scan of a patient 2 years ago. It was detected. So when they run Sybil actually look in this area highlighted in red. Sybil actually think that there's this process going on here. But obviously it doesn't, it's normal lung pleura, parenchyma, that there's really nothing in there 2 years ago. But 2 years later, admittedly, Sybil was able to accurately, to predict that a cancer will develop in that area. So very amazing work. Again, these are still in experimental stage. And I personally, when I learned about this technology, when they published it this year, I think this technology is very, very promising. So it will definitely help us a lot with patients. So we know that we can detect cancer very early on when we use this technology. So in summary, just some of the important points of this talk, like lung cancer is the second leading cause of cancer in the Philippines next to breast. We've talked about that the Philippines is a double burden of lung disease, as we both have a high number of TB and lung cancer cases. And this definitely poses a significant challenge since they can mimic the presentation of one another. We've talked about some clinical and radiological features which may help differentiate the two conditions. Sometimes when in doubt, you can refer to experts. And the recommended screening modality for individuals with significant smoking history is low-dose CT scan. Admittedly, currently we don't have specific screening guidelines for non-smokers. And I'd like to end my presentation with on a positive note. This figure represents that we've made definitely some significant progress in terms of improving the survival of cancer patients, like in early 2000s, and then a decade later. And this is where we are right now. So we've definitely come a long way a couple of decades ago. And of course, our aspiration is that we continually improve our patients' survival, which I believe can be done if we are able to detect cancer early and treat patients accordingly. So again, November is Lung Cancer Awareness Month. And once again, thank you for joining us in today's webinar. I'll be happy to answer some of your questions.
Dr. Samala, thank you so much for that very compelling presentation. We really appreciate it. I learned so much. There's so many good learning points for me, speaking personally, and also for all of our participants. And we already have a few questions in our Q&A box. So people are excited to start the discussion. So folks, as we begin our open forum, we'd like to thank our sponsor, Takeda, for helping make this webinar possible. Okay, let's get to it. Dr. Ken, so before the webinar, we were already having a little bit of discussion. So I'd like to kickstart by maybe focusing attention muna on you mentioned, of course, lung cancer rooted really in smoking. So how do we, just be very categorical, in your view, how do we accelerate parang the smoking prevention efforts in the country? Or I guess more meaningfully to our participants kunyari in their own specific clinical practices, no? Because changing that behavior is so hard. So you want to get, can I get your take on that?
Yeah, so good point, Doc Awi. No, so one thing I've learned is that multifactorial problems require multifactorial solutions. So basically, that's it. So, and I think for us as clinicians and for our participants who are joining, our general practitioner, our friends, and our family docs, I think the most important thing to recognize is that smoking cessation, or I mean, basically, if you're a heavy smoker, it's a multifactorial problem. It cannot be just addressed by just, you cannot just tell your patients, oh, don't stop smoking. It's bad for you. It's bad for your health. They don't usually accept that. So I guess the important thing there is to recognize first that it's a multifactorial problem, and there are several studies already that pointed that out. It's treating or smoking cessation entails a lot of like cooperation from several disciplines. So I think the most important thing is, just to get like pure patients to enroll them in certain programs. And I know for a fact that there are centers that actually offer smoking cessation programs that can definitely help them a lot. So definitely, they're like I said, like it's a multifactorial problem. There's definitely psychosocial intervention involved. There are like things that they can actually get, like nicotine, like patches that can also help them sort of like curb that addiction as well. So I think the thing is to recognize that there are actually programs, and it's not as easy as saying that selling your patient to stop smoking. It's definitely more complicated than that.
No, that's great. No, thanks for highlighting that, Dr. Kenna. So I guess the key takeaway there, enrollment in a smoking cessation program, no? Because, just advising your patient, that's not really probably going to be very effective. So seizing the bull by the horns, and then of course you mentioned nicotine patches, no? But then of course nowadays, so many other parang tobacco harm reduction strategies that are available, no? And of course, in our country and then all across Asia, there's that rise of vaping, no, and e-cigarette use. So I just wanted, maybe also, we had a little bit of discussion before. I want to get your take on that. So what I mean is that you mentioned a nicotine patch, which is probably kind of time and tested. That's a thing na you can provide to a patient. Yung vaping, kind of like recommending na lang the vaping and the e-cigarettes instead of the smoking. How is that as an approach in your view?
Yeah, so I mean, I'm not part of any like smoking cessation program, to be honest. So whenever I have patients, I encounter patients that are having a difficult time, like stopping smoking, I would usually refer them to the program. But vaping basically it's also introducing some foreign chemicals into your body. When you think about it, of course it has less amount of the chemicals that we usually see in smoking. But my take on that is that basically these are foreign chemicals and they enter your body. So I would like to think that there might still be some effect there. I mean, in some of the literatures that I've come across with, of course, it's still very new because vaping is a fairly new thing. It can also cause a condition called popcorn lung, which is basically popcorn lung. Basically, it's like inflammation, fibrosis of your bronchi. They call it popcorn lung because when you look at the chest X-ray, they really look like popcorn clusters. And I think that's and these are basically because of the inflammation and the fibrosis, and because our alveoli are kind of like shaped like popcorns, so you get like sort of like fibrosis in those areas as well. But of course, if these are there's very little information out there because again, like vaping is a new thing, but like I think of pretty much the same way that smoking, we didn't know that smoking caused lung cancer. like many decades ago. Initially, like smoking was being advertised as this fashionable, you're cool if you're smoking back in the 60s and 50s and 70s. They even allow people to smoke inside airplanes back then. So I mean, we didn't think that it was harmful back then, but time only tell. And eventually we learned that, it's actually causes some malignancy. So I'm not so keen on vaping, but I mean, I'll probably like be more careful or just
Sige. So your bottom
Yeah.
line recommendation, like probably not vaping, no? Probably not vaping or e-cigarettes, no? So therefore,
Yeah.
enroll in the program, no? And then that team that is part of that program in that hospital will probably be able to recommend an approach, no? Moving right along, Dr. Samala, there's still maybe 5 topics I want to tackle. Yung biopsy between like a percutaneous guided biopsy, na CT, at saka EBUS. Which one? This might be a controversial question, but I'm just curious, which one is better? Which one is
Okay.
what are the advantages or disadvantages? Yung phrasing ng isang question dito, no? So between EBUS and the percutaneous guided.
Yeah. So basically, it really is depending on the location.
Okay. Okay.
If the lesion, because lung cancer can practically grow like anywhere in the lungs, if it's more peripherally located, more on the side, more lateral. So definitely your CT guided biopsy can
Easier to
it's easier to reach that.
Great.
So that is the main indication, I would say, main indication for using or for going for a CT guided biopsy.
Sure.
CT guided biopsy, in a way, if it's lateral, it's actually easier to do. Less hospital time for patients as
Right.
well. But of course,
Is the CT? Which one? Sorry, I missed that. Which is less hospital time?
the CT guided.
The CT guided, right?
Guided, yeah.
So who makes a determination between, kunyari, the nakita na, di ba, between the CT guided and the EBUS? Who makes that determination? The oncologist.
Normally, yeah. So normally, I would still ask for help from the interventional radiologist. That's why
Right.
like the importance of having the MDT. So if it's more centrally located, so I think that would definitely go for bronchoscopy and then
For
EBUS.
bronchoscopy, right?
And then if it's more laterally located, in general, I think CT guided biopsy. So, but it has happened before. Like for example, I think probably this patient would, it would, like a CT guided biopsy would work. But when I consulted interventional radiologist, they would say, probably not. That's when you go to your to do your bronchoscopy and possibly EBUS.
Thank you, sir. Next topic. Your recommendation on well, actually not yours, but the United States recommendation, and then also the lung cancer recommendation, which is like annual low-dose CT scan. Great recommendation. And I think as clinicians, we subscribe to that, but that's going to be hard to do. That's really difficult to do obviously for access reasons, right?
Right.
Just paying for that. How does one approach that? And for the webinar participants, you'll recall, I think a couple of webinars ago, we were talking about access to cancer funds, for patients with hematologic malignancy. So Dr. Ken, can you kind of elaborate on that a little bit? So in order to do that, are there cancer funds that can be accessed by the patients? And then what's our role in helping the patient access those funds?
Okay, so the recommended screening modality is your low dose CT scan. In terms of pricing, that's around, I would have to say around 4,000 to 5,000 pesos, around that range. So in terms of cancer funding, for now, at least for now, it's not yet funded, but I know for a fact that PhilHealth and the DOH is working hand in hand in coming up with a funding. I mean, it's part of the universal healthcare as well. And under the universal healthcare, the National Integrated Cancer Control Act, or the NICA law, includes screening as well for cancers to be part of so basically they're developing a package. But of course, that's still in development stage as of the moment. So to put it simply, there's no cancer funds yet for screening, but hopefully in the near future, because we're moving forward to that direction. Well, hopefully in the future that can, be there will be a cancer screening package eventually.
So,
But
sorry,
right now,
yeah, just to, because we're running out of time. Can you describe, like, we were talking about that there's a guideline that's being formulated already. You're part of that working group. In order for PhilHealth, to use that as basis for, we will fund this. So can you, like, very quickly, can you describe that process? Where are you at now? And, para people are aware na that that's happening.
Okay, so the good thing is that ever since we talk about universal healthcare, the challenge is that we don't have local guidelines. So I think what POH did is to tap like several clinicians, several like epidemiologists to come up with local guidelines. So we worked on that probably a couple of years ago. So it's a very long and tedious process. Some of our clinicians might have an experience in doing local guidelines, but it's a very long and tedious process, but that's already been approved. So that's a good thing. It's already been approved by DOH. And I think right now, DOH and PhilHealth are now making their computations and coming up with, how to cover and fund it. I think that they're already in that stage. So those are kind of encouraging.
So we can see baka in the future, no? Like maybe into next year, into the coming year, we might get funding for that. Just super quickly, Dr. Samala, where yung low-dose CT, where is it available? Like, is every region, but there are hospitals with the low-dose CT scan available?
Yeah. So a couple of years ago, I actually worked with a team that sort of like mapped out where it is available. But back then, I know for a fact, of course, Lung Center of the Philippines has it. St. Luke's in BGC also has low-dose CT. If you're familiar with high precision laboratories, it's
high precision also has
it's the biggest diagnostic chain in the Philippines. I think their main branch in Banawe in QC has that as well.
It's not promotion now. We're just telling people.
So basically just to map out. Yeah. So there might be another. So that's what I knew like a couple of years ago. It might might already change since then. But those are the areas that I know for a fact have it.
Dr. Sabala, we have such a short time for discussion, but before we go, I want to talk about just a little bit lang. Can people give notes? Can you give our participants notes about the mutation screening? Because of course we know that nowadays that's kind of like really needs to be routine, diba? Like when you're diagnosed, when you have the mass, you really need to know the mutation of their patient, no? So can you just what is the routine, and then how much does it cost? Where is it available?
Okay, so like lung cancer is probably one of those mutation-rich types of cancers that we have, and also we have like sort of like treatment specific for those mutations. So normally, patients when they undergo biopsy, we do this test ideally routinely. I talked about mutation studies or next generation sequencing. So next generation sequencing is definitely that test that would more or less gives you a big or good overview of all the mutations present in the patient, but of course at a cost. So normally next generation sequencing, when it was first launched in the Philippines, I would have to say it's around 200 to 250,000 pesos.
Wow.
But I know, but it has gone down. I think right now we have like 120 to 150,000 pesos.
Wow.
But still,
substantial decrease, no? But still kind of out of reach, no? For the regular patient with lung cancer, no?
For an out-of-pocket economy like the Philippines, it's too much for patients. So we
so
do have that.
Away there, Dr. Samala. So yung NGS, kailangan talaga yun, di ba? Kasi kailangan lahat ng mutation makukuha mo. EGFR, ALK, ROS, all of those things, right? But then, pwede bang tingi-tingi? Like, di ba? Like, would you order something like that? EGFR na lang first, or ALK na lang? Or what's your approach? You described this earlier.
Okay, so ideally, like I said, like it's NGS. But again, in the Philippine setting, taking into account like our current like situation back home, we resort to sort of this stepwise or sequential testing. Sometimes we just,
Stepwise. Let's use the term stepwise instead of
stepwise.
tingi-tingi.
Iting-iting it, yeah.
Okay.
So
Stepwise.
basically,
So ano yung una? EGFR dapat first, diba? Or
only because it's the most one of the most common mutations
most common.
for Asians in
It's-
general. Just to compare it here in the Western Hemisphere, normally the EGFR positivity is 10 to 20%. So
Okay, wow.
but in
So yun yung priority, EGFR mutation first.
but
to
in
determine kung
Asia,
meron.
it's as high as 50 to 60% in Asia.
Wow. Okay. Right.
So just to like sort of like make an educated guess,
Mhm.
probably just do your EGFR first. And normally they, like most of them would be EGFR positive.
Sir,
you
tapos what's the next priority after EGFR and then next? So what?
normally, like in the NCCN guidelines, you recommend actually doing your EGFR, your ALK, your ROS1, PDL1 as well.
How much are those tests, sir? Kunyari, stepwise nga na EGFR na lang first. So how much is that testing?
Okay, so the good thing is that in the Philippines, I think because they recognize that it's very costly, there are certain companies that actually offer these tests for free.
Okay.
So for example, but just the EGFR tests or the ROS1 or the PDL1, those certain companies actually offer free testing for those.
Okay.
So that sort of like hopefully helps with the cost.
With the access rate.
Yeah.
I apologize to the webinar team and to our participants. We're a little over time now, but I just want to ask one final question to Dr. Sama. So, sir, I just need you to summarize for everyone. So, therefore, as a primary care doctor, as people in our audience, the primary care healthcare professionals who are seeing patients, with potential lung cancer, what is our role, therefore? Quick bullet points, sir, in the screening and diagnosis of lung cancer.
Okay, so I pointed this out. We followed like a lung cancer patient's journey, and the family docs, the generalists, the internists, you are the gatekeepers. So basically, you receive this patient. So you have a very, very important role. And I think the one thing is that you sort of like recognize. Hopefully the clinical features and the radiological features that we discussed a while ago can sort of like help us, like determine which is which, raises suspicion if it's malignancy or not. So there are certain features that would make you think. So I think that would be very helpful as well. And I think like I said in my last slide, when in doubt, when you're kind of like unsure, you definitely refer to experts just to help you clinch the diagnosis as well. But yeah, you do have
great summary, sir. Thank you so much. So again, being able to recognize very early, and then I guess helping our patient navigate through that, hoping that they're able to access the low dose CT, and hopefully maybe siguro mutation testing also, so that at least their path to management is a little clearer. Dr. Suwala, I'm so sorry for cutting off our open forum. We really appreciate your time and effort today. Thank you for your time and expertise on behalf of the organizations that have organized this webinar series and the webinar team. I'm delighted to present you the certificate of appreciation. So maraming salamat, Dr. Suwala. Appreciate it. Class 1998 would also like to thank those who helped make this webinar possible: the University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and our sponsor for this webinar, Takeda. A few important reminders on po. The first is I'd like to invite all of you to our next webinar happening this Wednesday, November the 22nd, 12 p.m. The webinar will be about the management of lupus. Our presenter will be Dr. Geraldine Zamora Abrahan, a clinical associate professor at the UP College of Medicine and a member of UPCM class 2005. You can use the same Zoom link to register in advance, or you can use the QR code shown here. Our class po, if you'll allow me lang to invite everyone to the annual UPMAS Golf Tournament on December 11th at the Ayala Greenfield Golf and Leisure Club. This exciting golf event will include lunch, giveaways, and a raffle, among other highlights. So interested players may register by scanning this QR code or typing bit.ly/UPMASGolf in your browser. Finally po, to receive your attendance certificate, there were folks on the Q&A just asking about the attendance certificate. ito po yung the way to get it. So to receive your attendance certificate, kindly answer the evaluation form, which you can access through this QR code. And then we will also post the URL in the chat box below. You will be able to receive lang po your attendance certificate only after answering the evaluation form. Now, so please ensure that the name you enter in the form is the name that you want to appear in your certificate. Once again, thank you so much for participating today. I'm so sorry we went a little bit over time. We hope that what you've learned today will be very useful in your daily practice. See you next time as we continue to unlock knowledge for primary care doctors and allied medical professionals. Have a great rest of the day. Thank you so much for joining us.